What's going on, everybody? Today we're going to be talking about Kendrick Bourne, who's a wide receiver for the New England Patriots. And on Sunday against the Miami Dolphins, he unfortunately suffered an ACL tear. So I wanted to go over a little bit more about what the ACL is, how people can rupture or tear their ACL, some of the grafts that we use for surgery, as well as some of the rehab guidelines and milestones that we're looking at before we think about an athlete going back to the field of play. Let's talk a little bit more about where the ACL is located and what its function is with regards to the knee. So when you look at somebody's knee head on, like this picture is showing, you have two cruciate ligaments, which are basically X ligaments that occur towards the center of the knee. You have one in the back, your posterior cruciate ligament or your PCL, and one in the front, your anterior or ACL. And so the function of your ACL is to resist your shin, your tibia, from coming forward. That's a direction that we call an anterior drawer force. The other function of your ACL is to limit a valgus or a twisting force, which is the same type of force when your knee gets pushed inward as if somebody's going to knock their knee together. Your ACL can also assist in limiting hyperextension, where your knee straightens out a little bit too far, and that acts as a passive check rein or kind of like a last resort to make sure that your knee doesn't hyperextend. When we talk about ACL injuries, sometimes an ACL injury can occur in conjunction with a meniscus tear, which is the washer that sits within your knee joint, as well as with your MCL. When we talk about how an ACL tear or an ACL rupture can occur, we typically have two major concepts. We have one where ACL injuries can occur during a contact type injury, which is unfortunately what happened on Sunday, where basically the knee can get twisted with an external force like another player or somebody falling on their knee. The other type of injury that we have is called a non-contact, meaning that the athlete was just running, they planted awkwardly and twisted their knee, maybe they hyperextended their knee, but basically nobody was around them, nobody made contact with them. There's a big push right now in the sports medicine research on what injury risk reduction strategies we can implement to limit people from tearing their ACL in a non-contact environment. So, we know that in sports medicine, sometimes, poop happens, right? So we know in sports medicine that sometimes, things happen, right? So it's really hard to control what other players do, especially in a contact collision style sport like football and rugby. But with some non-contact injuries, especially those that involve jumping, pivoting, things like that, like basketball and volleyball and soccer, how can we try to limit the number of ACL injuries that we see in a non-contact environment? So after somebody tears their ACL, we need to reconstruct their ACL ligament, right? So we have two, and there's a kind of budding third option out there about how we can basically use different parts of the knee to make a new ACL. And so the gold standard is using your patellar tendon. So if we look here towards the center of the chart, there's the patellar tendon, which is basically where the end of your kneecap runs down to the front bone of your tibia there. And basically the advantage of using a patellar tendon graft is that it has two bony ends on there. So after the new ACL is harvested, the ACL can be inserted and it's bone to bone healing, which is supposed to be the strongest type of healing that occurs. And the other thing too is that some people will complain about kneeling on their knee being a little painful because, as you can see on the drawing, the bottom part of their kneecap is essentially missing. The second type of ACL graft that we have is using your hamstring muscle. So kind of in this side picture here, there are two main hamstring muscles that can be harvested, and then they are bundled on or tied together. And the hamstring then is then inserted into the center of the knee. Unfortunately, the hamstring doesn't have any bony ends to heal. So theoretically, the healing sites where it's inserted may be a little bit weaker. However, we know from research that the hamstring graft itself is actually really strong. Now, there's also a third ACL graft type called your quad tendon graft that's shown here at the very top, where basically it's the top of the kneecap and then into the quad muscle or through the quad tendon as well. This is a little bit of a newer ACL graft, and when I was in Colorado, the orthopedic surgeons that I worked with out there, they actually preferred this type of graft because you do get a bone-to-bone healing because we have the top of the kneecap that can heal within the knee, and then also they thought as well that it was a very strong graft. So When we talk about which type is best, it depends on a few things. So each one of them has their own pros and cons. In the NFL world specifically, the patellar tendon, the first one that we talked about, is sort of the gold standard. And so if a rookie or somebody going through the combine had a history of an ACL tear, but they didn't have a patellar tendon graft, their combine or their draft stock could actually drop. However, each one of these grafts has their advantages and disadvantages. The hamstring graft is really strong, but the hamstring muscle can become a little bit weaker over time. Same thing, the quad tendon graft is supposedly very strong, but the quad muscle can take a long time to regain its full strength as well. And we'll talk about here in a minute why that's really important. So there's a few things to consider when we talk about ACL surgery. The first thing is that there's a lot of research now showing that rehab prior to an ACL surgery is actually very, very beneficial. There's a few things we want to achieve before an athlete has an ACL reconstruction, and that's making sure that they get their knee to straighten and bend all the way, so to get full range of motion, as well as to minimize swelling. And then the third thing that we're trying to do is to really get a very good quadricep muscle activity. Anytime that you have an injury to your knee and or swelling to your knee, your body's going to go into cell protect mode. This cell protect mode is going to shut down your quad muscle. That's why you see people where their knee will suddenly buckle on them, either right before their ACL surgery or even after their ACL surgery. The other thing too is that that quad muscle really helps to stabilize your knee. So getting that quad muscle as strong as possible, as quickly as possible, is our main focus both before the surgery and immediately after the surgery. So a lot of people ask, why is it that it takes so long for an athlete to come back after an ACL reconstruction? And part of it is due to that quad muscle inactivity, that neuromuscular phenomenon that we term arthrogenic inhibition. The other thing is that when we look at the ACL, there's small nerve endings within your ACL that are responsible for your body awareness, something called proprioception. When you tear your ACL, you lose that. Even when you reconstruct a new graft, you've lost that nerve signal. So we spend quite some time in the beginning trying to get an athlete's knee range of motion back, minimize swelling, and getting their quad muscle active and a little bit stronger. Once we do that, we transition to things like double leg squats, lunges, and then some single leg squats. This particular exercise and really test is called a Y balance test. And it's actually one of my favorite rehab exercises, not just for people after an ACL reconstruction, but for anybody with any type of lower body and or lower back dysfunction. And so basically what this test does is you basically do a three-way single leg squat. And so the first direction on the bottom left is she's coming straight forward. So it's a really good test of quad strength, ankle mobility, and just neuromuscular control. And then the second direction is out to the side. And then the third direction is out to the other side. So you basically make a Y. And what we can do is this particular kit has a ruler attached to it. And so we can actually measure how far you slide your foot in each of the three different directions on one leg versus the other. And we can compare your injured or the surgery leg versus the non-injured side. And so based off of that, we can get a what we call limb symmetry index, basically the percentage of how strong you are on your operative or your new ACL side versus your non-operative or your quote unquote good leg. And that can help us determine how ready you are to progress the next phase. So we've mentioned that the usual return to play time after an ACL reconstruction is about 9 months, and that's a pretty good estimate. There is a big push lately for athletes to come back a little bit faster, especially in the professional arena. Just know that that is not normal. That may not be the best thing for the athlete themselves. So there are some considerations, right? When we talk about coming back as quickly as possible, we have to make sure that the athlete's strong enough, especially that quad muscle. We talked about that arthrogenic inhibition where the quad muscle shuts down. The other thing too is that there's something called kinesiophobia or fear to move. When an athlete has a very long road to recovery, especially several months, there is a little bit of a hesitation where the athlete's kind of a little bit has some trepidation to make a hard cut, make a hard stop, take contact, things like that. And so you want to make sure that the athlete is not just ready physically, but also mentally and has really good confidence before they suit up. When we talk about some of the things that we're looking for, when we talk about a return to sport or return to play testing, we're looking at things like their cardio and their endurance. We're looking at things like their ability to decelerate, their ability to plant and twist on both legs, how strong they are on one side versus the other. All of things go into consideration. Kendrick Bourne's a wide receiver. He's been to a lot of cutting and pivoting, so he's looking at least a 9-month recovery.